Morning, one and all. Respected Dean Sir, distinguished invitees, well-wishers and students. On behalf of all the societies and trusts in KEM, I warmly welcome all of you to this academic award ceremony, a part of 93rd Foundation Day program. The societies and the trusts of KEM have brought you ORATION 2019. This will be followed by felicitation of Dr. Anand Narkarni Sir with Hirwai Sanman, an academic award ceremony in which certificates, prizes and medals will be distributed to our students for their excellence not only on university examinations but also in competitive tests, research and quiz. Let us begin our program by Dean Sir's address. I request our beloved Dean Sir, Dr. Deshmukh Sir, to please come on the dais and address the gathering.
Good morning. This is a preview to our 22nd Foundation Day celebrations which will happen tomorrow. And on behalf of KEM Hospital and the entire faculty and the ex-students of GS Medical College, I see many of them around. Good. So I welcome you all to this morning gathering of ORATION 2019, and we have back-to-back two lectures by eminent speakers who are specialized, subspecialized in this chosen field of gastroenterology and endocrinology. And I think it would definitely be an academic feast to all of us, and we hope that you carry a good message given by all the three stalwarts in this field of medicine. Thank you.
Thank you, sir. We now move on with the orations. The first oration is Professor Dr.U.K.SHETH oration. It is an honor to introduce Dr. U.K.SHETH, who was a professor and head of Department of Pharmacology from 1956 to 1978. Dr. Sheth established a clinical drug trial unit with a 30-bedded clinical pharmacology ward in our hospital with support from CSIR and pharmaceutical industry. It was a first of its kind in the country and was later recognized by the WHO. Even in those days, he carried out drug surveillance and started an adverse drug reaction monitoring program. He received national acclaim for his contribution to clinical pharmacology and is rightfully called as a father of clinical pharmacology in India. He worked as a WHO consultant on several committees and was a recipient of Dr. B.C. Roy and Shanti Swarup Bhatnagar Memorial Awards. The Department of Pharmacology and Therapeutics considers it a privilege to hold an oration to honor this eminent scientist. I request the chairpersons, Dr.Shobna Bhatia Madam and Dr.Nirmala Rege Madam and the distinguished orator, Dr. Philip Abraham Sir, to please take seats on the dais. I request Pallavi to offer them Tilbro as a mark of our respect. It's my privilege to introduce our chairpersons for today, Dr. Shobna Bhatia Madam, Professor and Head of Department Gastroenterology, and our second chairperson, Dr. Nirmala Rege Madam, ex-professor and head of Department of Pharmacology and Therapeutics. I request Dr. Shobna Bhatia Madam to introduce the orator of Professor U.K.SHETH oration, Dr. Philip Abraham Sir.
Good morning, everybody. It's a pleasure to introduce my own teacher. And today he's going to talk to us about bacteria. So let me go back about 30 years when the role of bacteria in the GI tract was still being explored. Even at that time, Dr. Abraham thought that there were many things more happening than just what were simple things that were happening to the bacteria, and the first paper that we went with that was the effect of lactobacillus on Helicobacter pylori. in vitro testing, 11 subjects, got accepted in a high impact journal, and today it has more than 150 citations. It's become a citation classic. Even today people look at that work. At that time we did a lot of microbiology work. We were on the 9th floor. Had to be stopped for various reasons. One of them was that Dr.M.V.L.Kothari, who was our microbiologist, passed away. So we stopped doing the microbiology work there. But even then he had many PhD students who were interested in microbiology and who continue to work on microbiology. When we look at the microbiome of the gut, simple to say that many years ago people used to say, keep your gut away from worms, drink clean water, diarrhea will not be there. And today we see a resurgence of diseases, not resurgence actually, appearance of many diseases of the GI tract, like Crohn's disease, ulcerative colitis, which have descended upon us in the last 20 years, and they weren't there many years ago. Many textbooks in the past said that they were not there. And how do we treat them today? We go back to our old simple fecal transplant. That means eating the same crap that we ate initially to give us infection, we now use it to treat diseases. So we have come a full circle from there. And of course, Dr. Abraham's contribution to all this has been massive. In addition, he had been the editor of the Indian Journal of Gastroenterology, an expert on methodology of writing, and teaching us all how to write papers, present papers, which put the department on a very high level in those days. I welcome Dr. Abraham to the presentation.
I request the chairpersons to take the seat in audience, and I request sir to start with the solution.
Thank you, Professor Bhatia, Shobna as we call her, for these words of introduction. A little problem about introductions is that sometimes you wonder if it's about yourself or this is imaginary, and it makes your job a little difficult to catch up with the words that have been spoken. But still, thank you so much, Shobna. Respected Dean, sir, our ex-Dean, Dr. Shivsagar, members in the front row who should actually be on the dais, who need much more respect than any of us who are on the dais today. If I have missed out any names, I apologize for that. Dr. Geeta Natarajan and all the members of the various societies who have been organizing this oration year after year. It's indeed a privilege to be here. I left this institution about 18 years ago, continued as part-time for another 8 or 9 years, and then I've been full-time out of this institution physically, but my heart and soul are still with this institution. A few words about my teacher. You already heard a lot of description about him, but what I want you to draw your attention to is the fact that he's one of those few Indians who has actually commanded a web page of his own on Wikipedia. I don't know how many of us have it here or how many of the people who we know have this. All the details about him have been listed here. He was an alumnus of this institution, then moved on briefly to the TNMC and came back to this institution. But that's the time that we got to know him well. I knew him as a teacher, he never knew me as a student because he obviously knew only the prominent members among the students. So we remember the days when we used to walk through the corridors of the pharmac department looking at those showcases that had a few drugs on display. Those were the days where we just needed to know the brand names of certain antacids, and when we talked about antibacterials, we knew sulfa and penicillin and their derivatives. Today, of course, you'll have the whole thing lined with medications if you have to talk about medicines, and I'm so glad that I was born before this day. Much has been said about the clinical pharmac unit being set up and about the various drugs in which Dr. Sheth has had a hand in development. You'll notice at the bottom that we talked about diuretics and drugs that we as gastroenterologists have been using in amoebiasis and trichomoniasis. Of course, the dose of spironolactone, which is now taken for granted, was standardized by Dr. Sheth. I should at this moment express a word of thanks to Dr. Ashok Vaidya because much of this information I picked up from the biography that he wrote of Dr. Sheth. So when I was invited to give this oration, Professor Sandhya Kamath gave me one condition. She said, you can talk on what you want, but please mention drugs somewhere in between. So although I was in the percentile ranking among the lowest 10 or 20 in the Department of Pharmacology, ma'am would remember that, but I still managed to put the word drug in the title of this topic, not because we are going to talk about drugs, but about whether I can introduce a concept in which we talk about drugs for infections and how we can target infection. We're talking about one infection, one organism, one drug. We're talking about a gut that is teeming with trillions of microorganisms. One drug, one organism, which is probably 1% of the entire population of the gut. Are we hitting the bacterium or are we hitting something more? So I just want to put you through the battlefield and then talk about the drug that we talk about. So, Dr. Kamath is here? No. Someone please tell her that I mentioned the drug in the title. Okay. So, till recently, and I'm talking about just 10 years ago, the stomach was meant to be sterile. We always thought that the stomach is a sterile organ because of the high acidity in it with a pH of less than. Any of the students can tell us the pH of the stomach is less than? One guess. 1, 2, 3, 4, 5, 6, 7. pH of the stomach is less than 2. Okay, so almost nothing should survive in that. So we talked about the stomach as a sterile organ. Oral cavity teeming with microorganisms. Esophagus just a transient tube or a transit tube. Stomach sterile, and then the small intestine starts multiplying the microbiome. That's the way we thought about it because of the low pH in the stomach. But everything changed. So that's our earlier knowledge. We talked about the stomach having a microbiome strength of anywhere from 0 to 10 raised to 3 CFU per grams. Now this was based on the culture of organisms, what we can culture by standard techniques and identify by standard techniques. Today we know that we were just scratching the surface. And that change came mainly with the discovery of Helicobacter, and I'll come to that later. But today we know that we have a stomach that's hugely colonized by a complex microbiome belonging to 128 phyla. And you've heard these names before, probably somewhere in your microbiology class. Dr. Nirmala, please take offense if you say, no, you don't know these. There's a high prevalence of non-H. pylori bacteria, majority of which are Streptococcus and Staphylococcus, and I'll come back to our work on that too. We also knew at that time, even with our preliminary knowledge, that lactobacillus was something that could survive in an acidic environment. So we knew that this was one organism which was always part of the 10 raised to 3, and being acid resistant, it would last or it could survive longer. So the thought that came to mind is this organism probably does something that helps it to survive in an acidic medium, and maybe that something can also inhibit the other organisms that are transiting through the stomach. It had products like antibacterial substances like lactic acid, hydrogen peroxide, and a few others that I've mentioned here. And even at that time, long before the word probiotic came into our lexicon, remember the word probiotic was defined more than 10 years later. So at that time, we just thought about, look, what's commensal, what's community living, what's antagonism, which of these applies to the various organisms in the intestine. Just rough thoughts, just wild thoughts at a time when nobody paid attention to the stomach as a site for infections. So like I said, the game changer came with the discovery of Helicobacter. And that I would like you to read, anybody who's interested in this, I would like you to read about this. It's written by Barry Marshall himself recently, where he talked about the history of discovery of Helicobacter. Those of us who know history will also remember that this was at one time called Campylobacter pyloritis, and then Campylobacter pylori, and then came the name Helicobacter when we realized that microbiologically it does not belong to Campylobacter. We know that this organism has been there, and we trace all infections to Africa, rightly or wrongly. We know that from the Stone Ages, this organism was discovered even in African skeletons. Prior to the 20th century, when we think hygiene started improving, before Swachh Bharat came into play, a majority of the world's population was infected by this organism. Even today, more than 50% of humans have been exposed to Helicobacter, so it's a rampant infection. We give credit for discovery of this infection to Warren and Marshall. They got the Nobel Prize, as you know. But long before that, there were people who suspected that this organism is there. There is something in the stomach it's not as sterile, and that's something probably is causing damage to the stomach. So we had what was called spirochetes discovered earlier. Then there was the histology that seemed to show something that didn't look like simple cells. And in China, they were using furodoladone for the treatment of ulcer disease long before we suspected that it was an infective condition. So there were clues that Helicobacter or something similar to that exists in the stomach long before Warren and Marshall identified this organism. So when they did that, they established a link between what is called disease and H. pylori infection. So we know acid-peptic diseases, as we know today, have been attributed to Helicobacter pylori. So they were the first to establish that there seems to be a link about this. So that seemed to have solved the problem about why there should be ulcers in the stomach. Acid, yes. Pepsin, yes. But why only in some individuals where everybody has acid and pepsin? So here I must make a mention that the term hyperacidity is really not true. More than 50% of individuals who have ulcer disease have normal acid secretion. So there's something additional that makes them susceptible to development of an ulcer, and that link seems to have been solved by Warren and Marshall, who talked about Helicobacter. So with that, we seem to have closed a chapter on the etiology of Helicobacter. But the problem was, it didn't seem to close everything. We actually opened up a Pandora's box. We now looked at a new infection and what we could do with that. So as I mentioned, it still affects more than 50% of the population around the world. Serological studies in India have said more than 80% in India are exposed to this organism at some time. Just as an interlude, I put a little number there. So those of us who want to go out for a tea break and come back know when to come back. We're still at 10 or 43, there's still 30 slides to go. Right? The issue before us even at that time, which even today we don't seem to have solved, is if this is such a rampant infection, 80% infected by this organism, how come 80% of the people in this hall don't have symptoms? Why is it that only a small fraction have the mildest of symptoms, that is dyspepsia, and an even smaller fraction develop disease, like duodenal ulcer or gastric mold lymphoma or even gastric adenocarcinoma? In this country, H. pylori is rampant, but in this country, gastric cancer is not rampant. In Japan, you don't see this infection, but you see gastric carcinoma. So what is it that makes some people with this infection susceptible to progression to disease, while others don't? We talked about the pathogenicity of this organism, we talked about host immunity. What we didn't think of at that time was the gastric microbiome. The thought that crossed our minds at that time was, this is one bug among hundreds of bugs. What is it that makes this virulent in some individuals and not in others? Okay, virulence factors, host immunity, yes. But is the rest of the microbiome lying quietly there as just bystanders, or does it have a role in the development of disease? And we bring this back later when we talk about therapy. Since Sandhya is back here, drug therapy for infections, especially in a battlefield that's looming with microbiota. So we looked at this, does the gastric microbiome have a role? Later on, of course, we looked at microbiome in the development of functional bowel disorders and irritable bowel syndrome, inflammatory bowel disease, and a host of publications recently on microbiome and gastric cancer. We'll come to that later. So we took this up in a very crude way in the late 1980s, that's 30 years back, Shobna? Yes. So we looked at it and said, lactobacillus is a commensal of the stomach, Helicobacter is an invader. Can these two get along, or is there one, in some way in which one can suppress the other? So we looked at co-culture of lactobacillus and Helicobacter and realized that the presence of lactobacillus actually inhibits the growth of Helicobacter. Very simple disc test, nothing fancy about it. Then we looked at the various products. We looked at lactic acid, hydrogen peroxide, and looked to see whether those things can also suppress. We obtained an inhibition with lactic acid, but not with hydrogen peroxide. So there's something more about lactobacillus that could inhibit the growth of what was then called Campylobacter. So the thoughts that came to mind is, at that stage, long before anybody talked about probiotics, is what do we know about bacterial interactions in the gut? What do some antibacterials do in gut infections? Do they actually target a single organism, or do they target the microbiome in which that organism lives? Where are we taking our drugs to? In vitro, yes, we know this works. in vivo, we know, yes, it works. How does it work? Does it target that one bacterium, or does it target the microbiome in which this bacterium resides? So these were thoughts that came to mind. Of course, nothing came out of that. We were in a simple ward in the great institution of KM Hospital, where resources are always limited. Another observation, about 25 years ago, it still is a common observation, and Shachish, my friend here, will remember that patients with irritable bowel syndrome come to us saying that when they take metronidazole, they feel better. So there was something in metronidazole that gave relief in what is essentially a motility condition, irritable bowel syndrome. So we thought, again, what is an infection doing with a motility disorder? Why is this bacterium giving giving harm to these patients? We are targeting a bacterium and we're getting relief from a motility disorder. So what is it that's there between metronidazole and irritable bowel syndrome? And because of this link between these two conditions, there was a diagnosis made of chronic amoebiasis. You probably have heard this term even today, haven't you? The term chronic amoebiasis suggests that amoeba can live in the host for a long time, which it cannot, because we know that in the life history of any parasite, you have to leave one host and get to the next host. So what is chronic amoebiasis? Then you talk about recurrent amoebiasis, but why should one individual in a family have recurrent amoebiasis when nobody else is getting? So this term chronic amoebiasis was established as a diagnosis only because patients on metronidazole would get relief of symptoms. And once in a while their stools would show that there are amoeba there, which all our stools someday would show this infection. So we checked this later to see, again, we did a simple manometric test, none of the fancy equipment that Dr. Bhatia has in her department right now, but we just shoved in a tube with a balloon, that's a police catheter, and attached it to a simple bedside manometer, and checked at the pressures in these patients with IBS. What we did find was that metronidazole, yes, did relieve IBS symptoms, but metronidazole did not change motility, unlike husk and the other drugs that we use for motility. So what is this mechanism by which a bacterium gives relief in a motility condition without affecting this motility? What drug are we using to target what in this situation? So the question that came to mind was this. This was in 1997 that we published this paper. It took another 3 years before we could recognize an entity called small intestinal bacterial overgrowth, and we said that patients with IBS have bacterial overgrowth. The drugs that we give to treat that infection are likely to relieve the symptoms of IBS. So it was another 3 years before this entity was diagnosed and now is part of our common vocabulary. So that's some of the beginnings that we had, and I think it's only appropriate that 30 years later I come back to the same institution to revive memories of those old days. It's come full circle, which is the justice of things. So we take a quick look at the gut microbiome. I'm not going into details, but for the undergraduate students, if there are any here, take a look at what it is. Did you know that there are 10 times as many bacteria in our intestine as there are in our body? So my question to you is, who's host, who's parasite? Right? So we are more bacteria than we are actually human cells. 10 times as much, and 1 to 2 kilos of that in a normal adult at any given time. There is high inter-individual variation, but in a given individual, there's long-term stability. Which is why if you treat a person with an antibiotic and his gut microbiota change, give it a few days, they'll come back. So we're never destroying it completely, except in extreme situations, but otherwise we're never destroying it completely. We're just changing it temporarily, and over a lifetime there's a stability. There's also a core of these bacteria that have a high housekeeping core. So one of the thoughts that crossed my mind many years later was, we have common phenotypes all over the world. Irritable bowel syndrome has common manifestations all over the world. The microbiome is obviously different in India from in Japan and the US. And if you're saying that the microbiome has a role in IBS, then how is it that the different microbiome leads to the same phenotypic change? So this thought just came to our minds, and one day over dinner with a senior member who's now in the WHO, Dr. Nair, who was the THST at that time, we just bounced this idea off him and he said, that's a good thought. Let's just take a look at what's happening to the microbiome in these individuals. We didn't follow that, but we looked at something that was more accessible, and that again came back to Helicobacter. So what we're talking about now, there are huge studies on metagenomic studies happening all around the world now, because there's billions of dollars being poured into this kind of research now, because we realize that this is probably the last frontier in the human body, or what used to be called the dark continent, the small intestine, is probably the one area that needs more attention than it has deserved in all these years. We know the gut microbiome as an endocrine organ. I'm not going to speak anymore. If Nalini had not been here, probably I could have tried my luck. But we do know that the gut is also an endocrine organ. We can see that. There are so many endocrine organs and the gut is one of them. What we don't seem to realize is that unlike the other endocrine organs, this can secrete more than one hormone. The others may secrete one or two. These can secrete a host of them. So all of us know that the gut is a huge endocrine organ as well. I've listed the substances that are being secreted by the gut microbiome and the gut epithelium. So if we take off the gut microbiome, we're probably going to make a big dent in our endocrine system. All the other organs, one hormone, two hormones maybe, here there's a whole host of them. So we know a lot about the gut as an endocrine organ. What we didn't think about all this time is the gut microbiome as an immune system as well. We know the intestine has its own immunity. We've heard about cell immunity, we've heard about secretory IgA, but we didn't realize that the microbiome sits in control of each of these. There's something called PAMP that regulates the immune response to the from the intestine by a host of intricate systems that I've just put up here. This is obviously not my figure, it's been stolen from somewhere, but the acknowledgement is there at the bottom. Same with adaptive immunity. So what we should know that the gut is also hugely responsible for immunity. So I come to the crux of what the message I want to share with you today. When we take the gut microbiome as a battlefield and we target an infection within that, are we targeting that infection? Are we targeting the microbiome? When you give an antibiotic, are you killing that one organism? We know it's not true that drugs are not so specific or so selective. But in the gut, where that one microorganism is one of tens of thousands, what are we doing to the battlefield? Is our victory at the price of destroying the microbiome, or is it a selective destruction of a bacterium? And here I'm going to use Helicobacter as a prototype because much of our work subsequently has been on this one infection. So our traditional teaching has been one infection, one organism, enteric fever, salmonella, eradicate that infection, eradicate that organism and the infection is gone. But like I said, what if this bacterium is residing among millions in the gut? Is relief obtained only by eradicating that one, or are we doing something to the organism as well? So before you talk about drug therapy, and I'm not going into detail in the presence of stalwarts like this, I'm going to only look at what is Helicobacter doing in the stomach. What is it doing to the microbiome? Is the presence of this infection making a change to the microbiome? Is the type of microbiome making a change to this infection? When we have patients with disease from this infection, what's happening to the microbiome at that time? Are we paying attention only to Helicobacter? Should we look beyond at the microbiome as well? So as I said earlier, we know this is the traditional teaching and we thought that eradication of this infection will control these conditions. We know that we use this even in early mold lymphoma. We also eradicate this infection in family members of those who have had gastric cancer. And we know that the WHO has classified Helicobacter as a class 1 carcinogen. That means if you see it, kill it. Of course, we don't do that now. We do it only in the high-risk individuals. Like I said, what is the role of the microbiome? And when you get relief from eradicating Helicobacter, is the relief really from eradicating that, or is it relief obtained by eradicating the rest of the microbiome? So this concept has been taken up in a big way around the world. Much of the focus has been what is the gastric microbiome in patients with gastric cancer versus those who don't have gastric cancer. Should we look at spices and cigarette smoking and alcohol and Helicobacter, or should we look at the environment of that stomach? So huge number of publications, I've just listed a few of them. I talked about Dr. Nair earlier, the person with whom we had dinner one day, and I'm not sure he likes or wants to look at that dinner evening with good memories, but that's when it all started. His institution, the THSTI, was at that time trying to find refined methods of isolating individual DNA from millions of DNA lying all over the place. So finally, they did turn up with a system which we published in Scientific Reports, a Nature publication, where a method that was refined by them could help to select out a DNA, 16S RNA ribosomal methods, but select out a DNA that could be isolated from the rest of the teeming DNA that's there in the microbiome. So we use this gainfully to study the microbiome in Helicobacter and in patients with and without symptoms and disease. So that's what we call a heat map. And I want you to take a notice about so that's where Helicobacter is. Take a look at the horizontal line. I'm sorry, I can't do it here. But take a look at the... Yeah, can you see that there? Yes. Take a look at the horizontal line that lies with Helicobacter. Thank you. That's Helicobacter, and that's the horizontal line. So the darker the shade of green, the more abundant it is. The lighter the shade of green, the less abundant it is. Based on this was a whole profile of Helicobacter positive individuals whom we had sent to the THSTI for scrutiny, and they said based on the prevalence of Helicobacter we could divide this group into 4. So we had group 3 with the highest concentration of Helicobacter, groups 1 and 2 had the lowest concentration, and group 4 was somewhere in between. So you could classify them into 4 groups based on the abundance of Helicobacter. We could also classify the cluster of organisms based on the prevalence or the abundance of the other organisms. So we had a cluster 1 here and a cluster 2 here, and you can see on the heat map to the naked eye that there is a qualitative difference between these two. So what we did find was that in group 3, where Helicobacter concentration was maximum, the diversity of other organisms was minimum. In groups 1 and 2, where Helicobacter was in low abundance, the microbiome was in high abundance. Group 4 was somewhere in between. So what we said is that as Helicobacter increases, the other microbiome seemed to decrease. What came first? Is it because the microbiome was less diverse, less Shannon diversity, that Helicobacter could thrive? Or is it the presence of Helicobacter that made the other organisms go down? We still don't have the answer to that. So if you look at that, to a concentration of around 0.25, the microbiome remains steady. This is the Helicobacter median abundance. Up to about 0.25, the microbiome abundance remains steady. When the Helicobacter goes beyond that, the microbiome steadily goes down. Which came first? Did the microbiome come first, or did the Helicobacter come first? So there seems to be a competitive abundance in the stomach between Helicobacter and the rest of the microbiome. We looked at the interaction between these. This again was published in Scientific Reports. You could see that with Helicobacter as the hub, all the others, cluster 1 and cluster 2, particularly cluster 2, the one in orange, all the others had a negative interaction with Helicobacter. More Helicobacter, less of the microbiome. On the other hand, when we look at the clusters themselves, cluster 1 would stay together, cluster 2 would stay together. There was a positive interaction between the various clusters. So these moved together as groups, and Helicobacter seemed to have an antagonism with them, which seemed to change either the microbiome or the other way around. We then accessed some samples from around the world, what we call a cross-geography comparison. There were 2 samples from China, one from the US and one from Colombia. What we did notice is that the cluster C1 that we called seemed to be common around the world. So that seems to be a core microbiome within the gastric stomach, which is shared across clusters. And where Helicobacter was absent, now I want you to pay attention to this, where Helicobacter was absent and the clusters were present, we had other organisms from Helicobacteriaceae that were present in these individuals. So the thought that came to mind is probably it's not only Helicobacter that's responsible for this. There are other urease producing organisms, there are other nitrogen producing organisms that probably can give the same symptoms in individuals that Helicobacter would. So that explains why some patients with dyspepsia don't have Helicobacter. They probably have others like Wallinella, and I'll come to one more organism later on. So while C1 tend to cooperate with each other, they are probably related to Helicobacter abundance. Then we moved away, so that was what's happening to the microbiome in Helicobacter. Now we're talking about Helicobacter with and without symptoms. So we looked at all individuals with H. pylori positive who either had dyspepsia or who didn't have dyspepsia. People have looked at ulcer disease, people have looked at gastric cancer, but dyspepsia outnumbers these conditions more than 10 times. So dyspepsia is much more common in the community than gastric cancer or even ulcer disease. So we looked at what causes dyspepsia in some individuals, what causes no dyspepsia in the others, and we noticed that the prevalence of the various organisms in the dyspeptic and the non-dyspeptic group were totally different. So for example, Staphylococcus was the commonest organism, being present in 90% in the dyspeptics and only 25% in the non-dyspeptics. So as you go down, you find the significant differences between these two groups. So there's more than just Helicobacter infection. It's also a question of what is the microbiome in these individuals. Why is it that some get symptoms, some don't? We attributed that to Helicobacter, but both these groups had Helicobacter, but there was a difference in the microbiome. Then, to complete the picture, and we're nearing the end of the talk, to complete the picture, we looked at those who don't have H. pylori infection. Now we know what happens to it when H. pylori is present. We know what happens when H. pylori is present with or without symptoms. Then we're looking at those who have dyspepsia or no dyspepsia but without H. pylori. And what happens, what we notice is, of course this is not yet published, that some phyla actually are more common in those with dyspepsia and some are less common in those with dyspepsia. So this attention that we pay to Helicobacter as a cause of dyspepsia, ulcer disease, cancer, malt lymphoma is probably not a complete picture. Our target should extend beyond Helicobacter and take a look at the microbiome as well. We actually tried to cluster these individuals based on, we blinded the microbiology department, the DHSTI. We blinded them and asked them whether they could find clusters of organisms in these groups. And they did. They found one cluster here, another cluster here, and when we went back to the clinical situation, we realized that this cluster was actually the dyspeptics and this cluster the non-dyspeptics. So based on cluster alone, you could almost predict whether these individuals will have symptoms or not. 75% accuracy in dyspepsia, 90% accuracy in non-dyspepsia. So you look at the microbiome and you can say, is this person likely to get this symptom at all, even in the absence of Helicobacter? So I want you to leave you with only this one thought. Look beyond what science says. Look beyond what traditional teaching says. Try to look at, isn't the human body much more complex than what we thought it was? Which are the organisms that we would isolate in those who are Helicobacter negative? You see that? Elizabethinia, way ahead in dyspeptics versus non-dyspeptics. So earlier we talked about Vollinella, now we talk about Elizabethinia. Are there other organisms that can produce the same symptoms that Helicobacter can? Remember, these are all H. pylori negative individuals. Again, this is only a last slide, maybe in this set. When we looked at the dyspeptics, the ones with the red bar here, and the non-dyspeptics, you can see that the microbial abundance in these two groups is far different from each other. So, going back to our original premise, there was a study that appeared just about a year back in Journal of Neurogastroenterology and Motility that said that when they treated patients with functional dyspepsia for H. pylori, they found that they responded yes with the antibiotics that they used, but the type of antibiotic you used for treatment of H. pylori seemed to make a difference. When you use metronidazole, the results are better than clarithromycin. When you give it for 10 days, the results are better than 7 days. And if they had associated IBS, their response seemed to be better. So that takes us back to the premise that we had 30 years back. In dyspepsia, of course at that time we talked about IBS. In dyspepsia, if you give metronidazole, the response seems to be better. Longer duration, better. If they had concomitant IBS, they seem to do better for the H. pylori symptoms. So our question was, does it mean that functional dyspepsia is not only Helicobacter pylori? Is it also related to the concomitant gastric microbiome, or is it also related to the intestinal microbiome, because we've used metronidazole and IBS right in the beginning? So, since intestinal microbiome has a role in IBS, is the relief of dyspepsia also only part of relief of IBS? Alright, so we're looking at the intestine or the GI tract as anatomically distinct: oral cavity, esophagus, stomach, small intestine, large intestine. Remember, this is a continuum. Remember, there's no hard and fast rule saying that this will be sterile, this is not. When we target one organ with the drugs that we have available with us, we're probably targeting much more than what we had expected. In all this, are we challenging Koch's postulate? Not at all. We're just giving it new wings for it to fly into wider horizons. So, in conclusion, ladies and gentlemen, and especially my young friends here, in a complex microbial environment, which is the battlefield, do we know the enemy? Are gut infections isolated, monomicrobial? Why do some pathogens become commensals and remain with us? Why do some commensals turn into pathogens? What is the enemy? Is it that one organism or is it the microbiome? Is the battlefield our enemy? When we talk about drug therapy, are we targeting the pathogens in isolation or do antibiotics destroy the microbiome or destroy the battlefield? So just a last thought for the youngsters here. Obviously, we have not answered all the questions. We've just touched the question and raised more questions about it. So remember that in a lifetime, you cannot answer all the questions or even one simple issue. In maths, maybe you can, but not in science, not in biology. Also remember that many of you may move on to basic sciences, but research in medicine is not only about labs, not only about basic sciences. There's a whole lot of clinical questions that still need our attention. And if you've answered even one of them, I think you've done your part in contributing to science. So before I walk away, trying to show that the entire glory is mine, it's not. I was just standing behind the scenes. The people who did the hard work are all there. In Hinduja Hospital, Dr. Verena Pereira, this was part of her PhD thesis also. She's not here, but she would have loved to be here and seen her work expanded like this. In KM, I have two particular people to thank. Professor Shobna Bhatia, who's head of the department now, and all of you here will also know Professor M.V.L.Kothari, who left this institution a few years back. In the 1980s, he was as much a part of the gastro department as we were. At the THSTI, we have Dr. Nair, Dr. Babatosh Das, and of course all the people who work in the lab. We also collaborated with the TCS, Tata Consultancy Services Research Wing in Pune, with Dr. Sharmila Mande and her scientists. I want to thank all of them and give them the credit that's due. Before coming up here, our dean had told me, Philip, are you really going to speak for an hour? I said, no, I'll try and restrict it to half an hour. Thank you.
Thank you, sir, for such a spellbound oration. So please. I call upon the chairpersons, Shobna Bhatia madam and Dr.Nirmala Rege madam on the dais. I request our Dean sir also to join us on the dais, please.
I would like to thank Dr. Sandhya Kamath for inviting me to chair this session. I'm very happy to have my friend Dr. Philip Agram. I don't know when he became my friend, but he was not just a friend, also guide and philosopher. And in Marathi we have a very nice term for it, that is mitwa. As Shobha said earlier, he was very well known and he's still well known, means I was saying he was, means when he was in KM for his scientific acumen, and he has helped us in putting our findings on paper, how to write properly, scientifically. And I remember my PhD thesis, the entire thesis, I had shown him, and he has gone literally through every word after word in that thesis and made a lot of changes also. Sandhya has not called him, there was a lot of deliberation in the department, and because U.K.SHETH is known as father of clinical pharmacology, as Deepika already said, and this is not pharmacology but also its application in clinical practice, and that is what you have been doing exactly all these years. So it was not the marks in pharmacology examination, but using pharmacology appropriately later on in the clinical situation. And he was an excellent teacher and still an excellent teacher. And you have understood that how he has taken you from our older concept of sterile stomach to the discovery of H. pylori, IBS, and all work they have done in the KEM hospital, which got published in peer-reviewed good journals, though there was a scarcity of resources. And now how that has been expanded further and how it was related to the clinical, how they have used the microbiological lab, the higher technologies, and the clinical signs and symptoms seen at bedside. So the message what he has said, I would like to reiterate, always look beyond what science says. Thank you.
Please give a round of applause to Dr. Rege. He has said everything what the director wanted to say.
Thank you, ma'am. Thank you, sir. I request Pallavi to bring the members. I request our chairpersons to felicitate Dr. Philip Abraham, sir, with shawl, Shrifar and memento. Ma'am, Professor and Head of Department of Pharmacology and Therapeutics, to present the mementos to our chairpersons as token of appreciation.
Design on the pot is by our nursing students.
Thank you, sir. Thank you, madam. I request you to take seats in audience.